Hey everybody, Dr. Rafich here. Let's fix this camera. There we go. Vet Triage. It is November 17, 3:43 p.m. Pacific Time, Sunday. We are starting a brand new journal and a brand new journal series, Veterinary Surgery. And we're going to be talking about regenerating mandibular bone using recombinant BMP2. This is part one. Immediate reconstruction of segmental mandibulectomies. This is coming out of the veterinary school in Davis, California. If we live stream tomorrow, which I believe we will, we'll be doing part two of this study. The objective is to describe a surgical technique using a regenerative approach and internal fixation for immediate reconstruction of critical size bone defects after segmental mandibulectomy in dogs. Internal fixation means that they're taking bones, but usually bones that are fractured, putting it together, and then stabilizing those bone fragments with implants that are going to stay internal to the patient. Contrast is external fixation, where the implants are holding the bones together, but the implants are on the outside of the body, not inside the body. Prospective study for dogs, treatment of malignant or benign tumors of the mandible. Mandible is the lower jaw, maxilla is the upper jaw. Methods: using a combination of extraoral and intraoral approaches, a locking titanium plate was contoured to match the native mandible. So locking means that when you put the screws in the plate, the screw head will lock into the bone plate. And then it says here, it's going to be contoured, meaning they're going to shape the titanium plate. Titanium is great because it's soft, but it's also pretty strong. So it's soft, meaning like it's malleable, you can bend it, but it's pretty strong. And also it's pretty inert, meaning that it's not going to really leach into the bloodstream, into the body, and also infection is a low risk. The plate was secured and a compression-resistant matrix infused with recombinant BMP2 implanted in the defect. The implant was then covered with a soft tissue envelope, followed by intraoral and extraoral closure. Results: the dogs healed, immediate return to normal function and occlusion, mineralized tissue formation was observed clinically within 2 weeks, and solid cortical bone formation in 3 months. CAT scan at 3 months showed newly regenerated mandibular bone, had about 50% of the bone density and porosity compared to the contralateral side. No significant complications. Okay, introduction. A common end result of critical size mandibular bone defects, meaning a bone defect that will not heal by bone formation during the lifetime of the animal, after segmental mandibulectomy, is malocclusion because of mandibular drift. Mandibular drift is when the jaw starts to move to one side or the other, and obviously it causes a problem with occlusion, meaning the teeth, the bottom and top teeth contacting each other, and so of course chewing and eating is going to be difficult or impossible. Malocclusion can result in difficulty in eating and drinking, prehension and pain of the contralateral temporal mandibular joint, the TMJ, on the other side. Autologous bone graft substitutes, microvascular tissue transfer, and distraction osteogenesis are examples of techniques available to address the problem. So distraction osteogenesis is when you take 2 segments of bone and you slowly you let them heal a little bit, and then you slowly separate them. And as you slowly separate them over time, that callus formation will continue to extend along with your distraction. However, these are still far from ideal because of donor site morbidity, scarce tissue availability, and limitation in graft size and contour. First, mandibular rim excision with preservation of the ventral border is a sound technique for small tumors in medium and large dogs. However, this technique is not recommended for more invasive tumors or in small dogs. Secondly, elastic training is a viable option for preventing mandibular drift, but requires good client compliance, and it only prevents mandibular drift in half of the dogs. Active compounds responsible for bone regeneration, the bone morphogenic proteins, BMPs, motivated, let me see here. A study showed that BMPs, so bone morphogenic proteins, are responsible for the initiation cascade of developmental events in which progenitor cells are induced to differentiate into bone cells, thus resulting in new bone. Recombinant human BMPs in the field of spinal fusion, fracture healing, and engineering of dental tissues have been used. The FDA approved 2 spinal fusion products consisting of either recombinant human BMP2 or BMP7 delivered via absorption into collagen matrices. The multifunctional growth factors of the BMP family comprise over 20 distinct ligands and play an important role not only in bone formation and remodeling, but also in development and regeneration of tissue damage. Moreover, BMPs induce a plethora of different cellular effects ranging from stem cell maintenance, migration, differentiation, proliferation, and apoptosis, because these proteins also play important roles in various other processes unrelated to bone, including iron and energy metabolism and adipogenesis, which is formation of adipose tissue or fat. Other studies have proposed naming this family of growth factors body morphogenic protein instead of bone morphogenic protein. Okay, material and methods. The CRM, which was the collagen, let me see it here. Compression resistant matrix, was made of collagen sponge with embedded granules of hydroxyapatite and tricalcium phosphate. And they also had, besides the CRM, they had the recombinant human BMP2, sufficient amount of the CRM to provide a half to 3/4 of the mandibular height and length, 2 millimeters greater than the defect span was measured. The CRM was infiltrated with 0.5 mg per ml of recombinant human BMP2 at a volume corresponding to 50% of the volume of the prepared CRM. The single titanium locking plate was a 3.0 millimeter Synthes maxillofacial plate. It was contoured before amputating the jaw, capturing the normal anatomic contour of the ventrolateral aspect of the mandible. Titanium locking screws were then placed. Dogs were fed soft food for 2 weeks after surgery, given ampicillin 20 mg per kg IV preoperatively, and then Clavamox 20 mg per kg orally twice a day for 2 weeks. Analgesia was achieved by opioids and NSAIDs for 7 to 14 days. Here is the picture of surgery. So you can see in part A, there's the ruler. They're measuring how much they're going to remove, and they're drawing it on the jaw there. Part B is they are pre-contouring the plate to match the natural jawline. And then C is removal of the jaw. You can see there's a big gap. And then 4 is putting the composite in there along with the plate overlying it. Results. Mean age, 8.8 years of age. Mean size, 29 kilograms. Segmental mandibular defect was 50.5 millimeters. Removal of squamous cell carcinoma and canine acanthomatous ameloblastoma. There were no rawhide chewing or rough play for 3 months after surgery. All the dogs had mild oozing from the intraoral incision by 2 weeks, but it resolved by 4 weeks. One dog had a small cystic lesion in the gingiva that spontaneously resolved after 4 weeks. Radiographic evaluation. Radiographic opacity of the regenerated mandible increased from postoperative radiographs to 4 weeks after surgery. We'll show you pictures of those here in a minute. For the 2 dogs examined, the repair tissues achieved 46 to 54% of the density of the contralateral mandible 3 months after surgery on CT scan. In one dog, the regenerated bone had similar to slightly greater porosity, 1.1 times, compared with the other mandible. And in the second dog, the porosity was much less, 0.4 times, than the other mandible. So this is just showing on the radiographs here progression going from A to E there. And if you pause this, you can look at where the black arrows are showing the defect, the junction of normal bone and the composite. And then it slowly goes away. That line goes away as the bone heals. Discussion. Histologically, previous reports confirmed that CRM infused with recombinant human BMP2 results in well-mineralized trabecular bone, reflective of healthy bone turnover and remodeling. In experimental studies using the same regenerative system, successful spinal fusion and mandible reconstruction in non-human primates, dogs, and rabbits because of robust formation of bone approximating native tissue was observed. The therapeutic outcome after using this depends on the delivery vehicle, the quantity, the concentration, and time of application. Using rhBMP2 without a carrier is contraindicated, and selection of the matrix used for delivery must be carefully considered. With regards to the concentration, a study that evaluated the application of recombinant human BMP2 in a rat cortical bone defect model found that the degree of bone formation is dose dependent. However, increasing the dose beyond a certain threshold concentration does not improve bone quality and may actually promote lower bone quality and invoke a detrimental and inflammatory response. However, in dogs with higher doses of RhBMP2, there was initial excessive bone formation, but this resolved after several months. And here's an image of the CAT scan. You can see there the white arrows pointing at the junction of the where the bone meets the composite, and then bone filling in section B there. The success of recombinant human BMP2 application in our approach was because of the presence of appropriate stem cells in the local environment and the ability to differentiate into bone-forming cells. Now that's, obviously they're assuming that. They're going based on the fact that all their dogs healed very well, so that's the theoretical reason why it's happening. Not theoretical, but they know that's why it's happening, but it's not like they're seeing these cells in any kind of testing. Although it is accepted that with increasing age, the quantity of stem cells decreases, the osteogenic capabilities of recombinant human BMP2 are not negatively affected by increasing age. In one dog, they observed a radiographic variation in remodeling where there was a rounded radiolucent bone void, but this resolved after 5 months. One study histologically confirmed similar appearing voids to be fatty marrow instead of normal trabecular bone marrow. BMP2 can induce adipogenesis, formation of fat, in addition to or instead of osteogenesis, formation of bone, through activation of transcription factor peroxisome proliferator activated receptor gamma, a key regulator of adipocyte commitment. PPAR gamma, that's the abbreviation for that transcription factor. Activation leads bone marrow stem cells to differentiate to adipocytes rather than osteocytes. And once this occurs, the osteogenic program is suppressed. Short-term BMP-induced inflammation is commonly reported on the 3rd day postoperatively. It peaks at 1 week, and it goes away by 2 to 3 weeks after surgery. This response is expected, and it's known to be a chemotactic for inflammatory cells, including mono and polymorphonuclear cells and osteoclast-like cells. Earlier reports described plate exposure through the mucosa in an attempt to reestablish the alveolar margin. These cases used more than one plate to buttress the defect. Plate exposure on the dorsal aspect resolved by plate removal and did not negatively affect the long-term excellent outcome. To avoid this complication, these guys recommend a single 3mm titanium locking plate on the ventrolateral aspect. This approach avoids iatrogenic damage to the teeth roots, is sufficient to buttress the defect, does not result in plate failure, and avoids plate exposure through the mucosa because the overlying soft tissues are not subject to mastication. Therefore, implant removal is unnecessary and would likely be difficult and traumatic given the osteointegration of the titanium plate and screws. For more extensive tumors, it may be prudent to stage the procedure because the use of recombinant human BMP2 in a tumor-laden site would be contraindicated. They're saying that if you have any doubt there's tumor cells left behind, then putting the composite in that bone defect is contraindicated because it's the tumor cells are not going to help with the healing, or maybe it could promote cancer formation or spread. The pre-contoured locking plate could maintain the occlusion until the tumor-free margins are histologically confirmed. So what you would do in the staged procedure in more advanced tumors is you would pre-contour your titanium plate, remove the bone segment, place the implant, no BMP2, and then wait till the biopsies come back. And if it shows that your tumor margins are free, then go back in, remove the plate, put the composite in, put the plate in, and then you're good to go. This requires a second surgery to place the composite. So a pretty cool study. We'll talk about part 2 tomorrow. Obviously we want a larger number of dogs. This is only 4 cases, but jaw tumors that require this extensive surgery are not that common. So, and who knows what this type of procedure costs the pet owners, but that's a really cool study. It's great seeing more focus on regenerative techniques rather than really crazy surgeries that we often do in dogs. All right, everybody, thanks so much for watching. Thanks to those watching in the playback. We'll see you again tomorrow. Bye-bye.